Good morning. Welcome everybody to our Coffee, Kids, and Sports Medicine this morning. I'd like to thank you all joining us in the audience as well as those of you online. As always, a couple housekeeping items to go through. First, just wanted to mention some of our upcoming online events or on-demand events. We'd love for you guys to log in and join us for those as well. These will be available for you to kind of get back to as well. If you miss them live, we can get you back on with the on-demand function. Some of the upcoming events for July, the next one for Coffee Kids and Orthopedics is evaluating DDH in the newborn, as well as August 16th is going to be our shoulder instability in our young athletes. We have no relevant financial disclosures for today's discussion. Today's speaker is Dr. Shane Miller. Dr. Miller is a pediatric sports medicine physician. He has extensive experience with sideline coverage of both youth and professional sports teams coverage. He is currently on the board for the concussion safety oversight committees. He takes return to play guidelines seriously. We're grateful that he has taken the time to put together today's talk as it can help us navigate returning some of our young athletes after COVID-19 infections back to their sport. So if you guys will welcome Dr. Miller.
Thanks, thanks, Jared, and good morning, everybody that's here in person, and thanks to those of you who are joining online or watching at a later date. So, all right, so we're going to get going here, and I am going to make this talk relevant, even though it seems like this talk is 2 years late. This talk is going to be relevant because the nice thing is now we can actually look back with a retrospectoscope and kind of look back and see some actual data and some evidence for the things that we're currently doing. And we'll kind of travel back through time a little bit in the way that we manage some of this and how we've gotten to where we are today and why we're where we are today, so that hopefully we'll all leave here leaving comfortable with kind of what's going on. So here's the first question. So again, if you'll go to slido.com and you can enter in multiple words. You can enter in one word at a time and enter in multiple responses, but just kind of, we've been through this for 2 years, COVID-19 and sports. What comes to mind? So people that are online can do the same thing, please. Feel free to log in and put in some words, and let's see what we've got here. And again, you can put in multiple words. So just hit add response. Once you put it in, you can start to put some more in. The bubble. Endurance. I see several for endurance. Yeah. Cardiomyopathy. Gradual return to play. Fear. That's good. We'll give it a few more, 30 seconds or so more. See what else keeps coming up. Regulations. Lots of regulations. There you go. People are starting to see gradual return to play. Rising to the top. Cool. All right. Very good. So, kind of interesting to see what comes to mind. And I almost said what comes to mind when you think of COVID-19 and just left it at that because I kind of wanted to see what everybody's perspective is just on that, but I said, well, it's a sports talk, we'll make it relevant and see. So a lot of you guys went to kind of more relevant things for this talk. So let's see where we go. So our objectives today are to describe the current recommendations for mitigation of COVID-19 transmission risk associated with sport participation, to discuss current consensus and UIL guidelines for return to sports after a COVID-19 infection, and identify which athletes require medical clearance prior to return to sport participation. We will be using SARS-CoV-2, COVID, and COVID-19 interchangeably, so that's going to be the same thing we're talking about. You'll see some of the presentation or some of the studies call it SARS-CoV-2. So, bringing us back, March 12th, 2020. I think this was when it hit me that this was real in our sports world. We were already kind of aware that there were some cases. And I was, I remember seeing on TV that March Madness was canceled. And that when they cancel March Madness, it's serious. That's a big deal because they're not going to cancel that for something that's not going to be very significant. So that was a big deal in terms of the sports world. And then soon after that, so March 17th, we had these stay-at-home orders. So 6 Bay Area counties, this is from San Francisco, 7 million people ordered to shelter in place, right? So March 2020, we are starting down this pathway of confinement, restrictions, restrictions from school, restrictions from sports. We've canceled our sports now, and where are we going? There's so much unknown, right? We didn't know much about this virus. We know a lot more about this virus 2 years later, and that's really nice and exciting because, again, I have data to share with you today, but we didn't, and we all lived through this, and so that shaped a lot of how we got to some of the early recommendations. Anybody that's been here, so, okay, I've sent your history report to my boss, and now let's go over my team's marketing plan with your class. When working from home and remote learning take a toll. So March 2020, anybody else who tried to homeschool their child? I see a few hands. And meanwhile, running your full-time job and trying to keep your family safe and figure out what's going on. So it was a little chaotic, a little bit chaotic. And that was from the adults' perspective, right? But what about the kids? What about our athletes? They had everything taken away from them. In terms of, there's been a lot of data, and I'm not going to focus on it today, there's been a lot of data, even studies that we did here, looking at, mental health of the adolescent athletes as they, were pulled away from school, pulled away from their friends, pulled away from socialization, pulled out of their sports. Sounds familiar. That sounds a lot like what we used to do for concussions, for treatment of concussions, and we realized it didn't go very well for our teenagers. And so then we said, okay, wait, we need to kind of get back to getting them back to their normal life sooner after a concussion. Well, we didn't really have that option at that time, right? Again, there was a lot of unknown. So physically, when we start to look at our athletes, there's also been a lot of data that's come out. So this is a study that came out last year looking at, this is from CHOP, and they looked at over 500,000 outpatient visits that came through their facility. And they looked at the rates of obesity in all of the children that came through, and they saw a significant increase in the prevalence of obesity, both from 2019 to 2020. So within a year change, saw a significant jump in obesity over that. And you imagine from March up till June, so just a few months of home confinement and COVID restrictions there. Unfortunately, disadvantaged groups were significantly and disproportionately more affected by that difference there. And younger kids, 5 to 9-year-olds, some of our elementary school kids were significantly more affected. And so they concluded that efforts to reduce the COVID-19 transmission have also likely contributed to the worsening pediatric obesity because the trend and the jump was more over that 1 year period than what they had been previously seeing. And families were managing that difficulty of, again, virtual school, limited physical activity, and increased reliance on more heavily processed and calorie-dense foods. We didn't have access to the grocery store. We didn't have access to some of the restaurants that we normally make. And so everybody was just trying to survive and get by. Families that may be living in a small apartment, multiple generations, may not have access to some of the resources or outdoor parks or fields that others, more affluent athletes had. And so, after that period of confinement, then, significant implications of that. This was looking at Austria. I thought this was striking. They looked at 700 kids, and they actually had data on them both pre and sort of during the pandemic, and they followed them along from September of 2019, so pre-COVID, and then in June of 2020, September of 2020, March of 21, and June of 2021. And you can see the trends there. This is the BMI that I'm showing you there. So significant increase in BMI and also in waist circumference were found. So these kids were getting significantly bigger between pre and pre-confinement and after. So this is a significant challenge. They also had testing on that. They did a 6-minute run to look at their cardiorespiratory endurance. They looked at, they did shuttle runs looking at their speed, and those were also significantly decreased. So they were getting bigger, they were getting slower, they were losing their aerobic endurance, and a big challenge. So again, the COVID-19 related mitigation measures intended to contain a communicable disease resulted in an acceleration of the pre-existing pandemic of overweight and obesity, a real challenge that we are now going to be dealing with for a long time. Looking at more effects on COVID confinement. So now when we start to look about, again, unaffected, healthy kids. These are kids that also had these are kids that came in for cardiopulmonary testing, exercise testing, and they compared 10 kids after the pandemic to 10 kids before the pandemic. And they found that the VO2 max in those who the post-COVID cohort was significantly lower than those who came in pre-pandemic. So again, healthy kids, not necessarily athletes. We're just looking at children in general. They were losing access to physical activity. They were losing access to physical education, PE classes at school, obviously whatever organized sports they may be involved in. And only one patient out of the group of 10 after COVID had a higher VO2 max compared to their pre-COVID match, and that was the one varsity athlete. So all of the other non-athlete kids had even more of a drop-off. The one athlete actually did okay. So we don't know what that athlete was doing during the pandemic. And so again, a measurable decline in physical fitness. And so that's a real challenge. This was a study that looked specifically at elite adolescent soccer players, so teenagers. And this team, this club, what they did is they actually had their athletes continue training during the pandemic. So they had them, normally they would train 4 days a week and have a game 1 day a week. And so they continued with their 4 days a week of training, and they just converted them to home, web-based, and the coach would monitor them. So 2 days a week they did cardio, 2 days a week they did strengthening and high intensity training type stuff. And so again, these are elite soccer players who continued training supervised over the pandemic, and they were there on the web, Zoom type, meeting, and they had them perform the yo-yo test, which is similar to the pacer test or the beeper test. You guys are probably familiar with the shuttle run, where you have a certain amount of time. There's a beep, and you have to run from a cone and then back, and then it beeps again. And so every time it beeps, you have to run and you have to get back in time, and it kind of goes faster and faster, and you got to keep up. So it's a good endurance test. And these kids, these again, elite soccer players, the running distance decreased by 25% on their pre and post yo-yo tests. They also had a decrease in their maximal running speed that was significant. So it was 5% decrease in their max running speed. And so they said confirming detraining. And again, these are elite athletes that continued training in a supervised fashion, and we still saw these significant drop-offs. So you can imagine what's happening to the average kid or athlete who may or may not be training or training on their own over this short course of time. And this was not a big gap here from what they looked at. So they determined, they concluded the confinement period represented an exceptional situation that led to detraining despite a home program of exercises. So that detraining is a significant issue for us to be aware of and to focus on as we think about, kind of getting back into play as well. So we talked about some of the physical effects. What about the financial effects? So this was a study estimating at the time the losses for some of the professional sports. So the Major League Baseball, NBA, NFL, and NHL, and they estimated that it was going to be over $6.8 billion in losses for the 2020 season, just based on ticket sales. Right? That doesn't include sponsorships, that doesn't include TV, that doesn't include concessions, and all the other profits they make. They're saying just based on the fact that they're not going to be spectators in the stands at these games, even if the games go on, they're going to be losing $6.8 billion among these leagues. So you can imagine that there was probably quite a bit of motivation from certain forces to get sports going again. So then there were a lot of creative minds that said, all right, this is not going to fly. How are we going to get back out there? So one of the questions that comes up, of course, is what is the risk? What is the risk of us when we get back out there pushing through and getting back? And so one of the biggest concerns was at that time, right, still the risk of transmission. So if by playing sports, is there a risk? Are we going to be getting people infected and continue the spread of this pandemic? So this is our next slide. So again, we'll go back to Slido, and I'd like you to go back to the website. Which of the following sports has the highest risk of COVID transmission? Football, baseball, wrestling, gymnastics. This is where I would learn to probably not show the results until after you guys have done it so that you don't look at whether people have answered and let it influence you. So I'd like you to chime in. All right, so we got a lot of interest in wrestling and football. Nobody thinks baseball is high risk. Nobody thinks gymnastics is high risk, apparently. All right. So let's talk about this. Let's go through and talk about some of these sports. So good. I appreciate you guys interacting. Okay. So this was April 2021. The CDC director says that the United States is seeing rising COVID cases associated with youth sports. It's a bad look. It's a bad look when the CDC director is coming out and saying, hey, we don't think that going back to school is bad, but going back to sports is not going well. There's a lot of outbreaks here. And so for those of us in the youth sports world who like to see youth sports going on, and this is now a year into the pandemic, this is a concern. So between January and March in 2021, Michigan had 291 outbreaks that they related to youth sports teams alone that involved at least 1,000 people. In Minnesota, the new strain rapidly spread through a county with at least 68 coronavirus cases linked to participants in school and club sports, hockey, wrestling, basketball, skiing, and other sports. And so there was a lot of concern about what does that mean. And so then the question is that from the sport itself, or is that the community spread related to what's going on with the actual sport? So that's something we have to kind of answer. All right, is it being out there and playing? Is it playing hockey that's causing the COVID to be spread, or is it being around people and traveling and sitting there in locker rooms together and carpooling together to the game and then going to dinner after the game? And so what is it that's kind of going on? So here is an example of, this was a June of 2020. CDC put this out about an outbreak of COVID associated with a recreational hockey game in Florida. This was adult, not youth hockey. This is a recreational league. And so there was a player. They're all asymptomatic at the time of the game, okay? So June 16th, they're all asymptomatic here. Here's the hockey game. The next day, somebody tests positive, okay? And then after that, you see the trend over the next 5 days that you see both teams. So primarily the team that the index player was infected on. So you see that's the dark blue here, but also the other team, and you also got one rink staff member. 14 out of the 22 players on the ice developed COVID, and that was the 14 that had symptoms, and of those, so they only tested those with symptoms. So they didn't test the asymptomatic ones. This was still early on at that point. And so we don't know if any of them had COVID, but a pretty high transmission rate related to a hockey game, and you're seeing team-to-team transmission. So it's not just within that one team or on their bench. So here's looking at a wrestling tournament. So this was 10 high schools competed in a wrestling tournament. They were two back-to-back tournaments, a one-day tournament and then the next day another tournament. So one school hosted a back-to-back tournament. So they had 5 schools one day, they had 5 schools the next day. So a total of 10 schools came in from 3 different counties and played or competed in this tournament. There were 130 different attendees, and that's not all wrestlers, but coaches, referees, and others that were there. And they were able to test about 54 of them afterwards. So because once somebody tested positive a day after the tournament, again, not positive at the time, and they found that 38 of the 54 people that they tested were positive. So that's 70% of the people who tested and ended up having COVID. And even if you assume everybody they didn't test was negative, it still means that 30% of the people that attended that wrestling tournament ended up getting infected from that one index case. So we start to look at that, and then you see these are comparing to the tournament attendees. You had a little peak right there, but then you also had some of the school contacts and the household contacts. This was after this was when we were still doing more contact tracing. Early on, they were following and said, okay, well, you've had a contact, now you're going to go have these household contacts, and so they were able to trace some of those people, so above and beyond the 130 that were there, and then they ended up canceling athletics, and then school ended, and then it kind of went away after that. So we were making a lot of changes. This is a picture of one of our sidelines with the bottles. We all had individual water bottles. Everybody, and we wouldn't touch them. The athlete would get their own water bottle. We had them grouped by, player position. So linebackers, D-line, O-line, had their own, and we were trying to keep them in little cohort pods, and try to keep them separated. So we didn't want to interact and didn't want to mingle because of the contact tracing. So if you have one offensive lineman that goes down and you lose, all of your defense and all of your quarterbacks and your running backs because we were all working together. So if you keep them separated, maybe you wouldn't lose everybody from contact tracing at that time. So there were a lot of changes that we were making, trying to stay ahead of the curve and trying to really decrease the risk of transmission because there was a lot of concern about that. So we went back, and we're going to talk a little bit about this in a little bit. But the Big Ten and the Big Ten and the Pac-12 canceled their football seasons for 2020, and we'll go into what happened and then come back. But we didn't know, right? We didn't know what was the risk of these sports. So eventually, we had a football season in 2020, and we're able to look back at the data and see what happened. So the SEC, obviously a lot of resources, a lot of funding, was able to get a lot of really good data. And so they played a football season from September to December 2020, still pretty high COVID rates. They had 1,200 athletes, and they had over 100,000 player-to-player interactions with opposing player teams, 64 SEC regular games. The interactions ranged from 1 second up to 380 seconds, so over 6 minutes long. They averaged about 6 seconds long, but 95% of them were less than 25 seconds or 26 seconds in length. So very short, brief, quick interactions on the field with opposing players. And they actually, what they did is they had tracking data, tracking software. So they were able to, do this all electronically and using the computer tracking software that tracked the players on the field, their interactions, and so it was all very accurate. Accumulated contact time between two players during a single game was fewer than 23 seconds average, and 95% of the time, the contacts between two players were less than 97 seconds over the course of an entire game. Not very long, right? Now remember, at the time, what we were talking about for contact tracing and isolation is 15 minutes. So greater than 15 minutes within 6 feet of unmasked exposure, you were considered to be a positive contact. So on a football field, at least at a high level in this SEC, in general, you had an interaction with another player of only 97 seconds during the actual game. And only out of the entire season, they only found 13 player-to-player contacts who had cumulative in-game time greater than 15 minutes. So whether it's an offensive and defensive lineman who may have been engaged every play, I don't know, but that's not very many that would meet the criteria for positive contact. So over the course of the season, they had 11.6% of the players who tested positive. But only 1.5% of those tested positive within 48 hours of playing in a game. So trying to look at if there was was it related to the game there at all? And then they followed them on for 2 weeks after the game. They did contact tracing and found that the 18 players who had contact, none of them were considered direct exposures because they were less than 15 minutes, and none of them who tested positive ended up in having anybody else that they had contact with get infected. So they determined that there were no instances of in-game COVID transmission were found during the entire SEC 2020 season. So I think that that's a pretty good data to sort of say that maybe it's not the playing of the football that's causing it. Now, in fairness, the SEC had a pretty good screening protocol, right? They were testing athletes on a regular basis, especially in 2020, before the games. And so they were trying to weed out a lot of the positive patients. So there weren't as many COVID positive athletes getting onto the field, hopefully. But I think that that's also evidence to sort of say, if we have good mitigation guidelines, then perhaps it's not the sport that's the problem. And so these rates are not necessarily higher than the community rates of transmission, especially on a college campus where you have student athletes interacting with their peers, or high school student athletes interacting with their peers, teachers, and otherwise. So we take it up to the next level. So we look at the NHL, the National Hockey League, decided to have a bubble. And so to have their playoffs, so we went, and I can't neglect to mention that here's my Dallas Stars playing in the Stanley Cup Finals. It's a pretty surreal picture, right? This is the Stanley Cup Finals going on right now, right? We have Colorado and Tampa Bay playing right now in the Stanley Cup Finals, and there is nobody in the stands. You see the benches, but there's nobody there. I don't know that we'll ever see this again. I hope we never see this again, in our lifetime, that there's no spectators at the national championship at the highest level. And unfortunately, my Stars came out on the wrong end of this, but it's pretty cool. So the 2020 playoffs, the league ran the tournament. They brought 12 teams from each conference, so 24 teams, and they had them in 2 different venues, one in the East in Toronto, one in the West in Edmonton. And over 65 days, 24 teams, 5 rounds of playoffs, 2 bubbles, 33,000 COVID tests, 0 positive results. 0. After 2 months of being around each other and doing things. So the bubble worked. Now, if you talk to a lot of the players and the coaches that were there, they didn't enjoy it. It wasn't fun, but you can do it, right? And so again, is it the hockey that's causing the COVID transmission, or is it just being around people? And so when we're talking about this, we were seeing Michigan and Minnesota, the hockey outbreaks there, and so that's certainly a challenge, but it's not maybe necessarily the hockey, but you are indoors, you're breathing heavily, you're in close contact, so it seems to be higher risk than a sport like football, like SEC, where you're outdoors and you have less of the contact there. So then let's move on to the Olympics, another international stage. So this was 2021, even though it was the 2020 Summer Olympics in Tokyo. They screened everybody who came to the airport. So 54,000 tests conducted at the airport, and only 55 tested positive there. Those were 0.1%, so pretty low rate that came through. It's pretty good. They did over 1 million screening tests during the Olympics and Paralympics. It's a lot of tests. That's the athletes, that's the coaches, that's their entourage, that's volunteers and people that were there, officials. And they had 299 positive results. Now again, these were screening tests. They're not testing just symptomatic people, but you're looking at 0.03% COVID rate there. So again, fairly successful. They were able to pull it off. Here's looking at what happened. So I put on the arrows there so you can see the opening ceremony. Obviously, a few cases early July 4th, and then people starting to arrive getting into the village and coming into the country in preparation. So you start to see a little bit of a peak, and then you have the opening ceremony, and then it kind of continues to climb. And then you have the closing ceremony, and it goes away. And again, is that the sports, or is that just the interaction? And then the Paralympics come about 2 weeks after that, and people are arriving for that as well. And then you see the dip off as well. So successful. And then you move into the Winter Games, Beijing 2022. Again, thousands of participants, 91 countries represented. This is absolutely an international event. And you guys may recall there was a lot of uproar at that time because the country was really still, essentially in lockdown. And they were very worried about bringing this, trying to host this event when they were not even focused on their own well-being at the time. So China ran its system on what they called a closed loop. So similar to the bubble in the hockey, that participants and venues were confined to epidemiological bubbles, and they were segregated from the city at large. They didn't want to have a lot of interaction, and whether they were trying to protect the citizens, it says to protect its citizens, probably they were trying to protect the athletes and to protect the image, right? Is that if we have a lot of commingling between, then you're going to have community spread, and then you can't pull it off. So they only had 437 infections, COVID positive tests over the time. And again, 180 athletes and team officials tested positive. So out of those 437, only 180 were athletes or team officials. And a few people ended up missing their events, and you heard about some of those, but there were no major disruptions to events caused by outbreaks. So Thomas Bach, who's the IOC president, said the infection rate at the event stayed at 0.01%. So again, another example of success, and that perhaps the sports are not the cause of the transmission and can be played safely if we implement the right COVID transmission mitigation guidelines. So this was one that I particularly recall, and I liked her story. She is an amazing bobsled athlete who, unfortunately, when she arrived in Beijing, January 27th, and then on the 29th, 2 days later, she tested positive for COVID-19. She said she was symptom-free, but then she had to go into isolation. So you can imagine mentally and physically as an athlete arriving to prepare for the Olympics and then feeling okay, but you have to go into isolation. You can't leave your hotel room. You can't leave your room. You can't be around your teammates. You can't go train. You can't go look at the track and start to look and prepare yourself for what you're going to do. And she's, by the way, a new mom who's still breastfeeding. Okay, so pretty challenging mentally and physically for her. So what does she do? They bring her a barbell and she starts working out. I love the athlete's mentality, and they're just we're going to overcome whatever you throw at us. And so she posted, and I don't have the video, but this is her, in her hotel room there in a little small room. She's like, I'm just going to go for it. I'm going to keep working out. And again, she was asymptomatic, so they kind of worked a little bit. This is on February 5th. So now we're looking at, a 5-day period from her time of testing positive. She's back in here working out again in her room, still in isolation at that time, and our protocols there. So how'd she do? Well, February 13th, she won the silver medal. And then February 19th, she won a bronze medal. Pretty good, pretty resilient, amazing athlete. And then here's her son holding her silver medal. So, a success story. So I think that, they isolated her to try to mitigate the risk of transmission, and then followed guidelines, and she was able to gradually get back into things, successfully maintained her endurance, and was able to go out there and compete at a very high level and achieve her dreams. So again, if we didn't utilize some of the data that we had early on, or if we kind of reacted without looking at the data, then maybe the Olympics would have been canceled. Maybe this opportunity wouldn't have happened. Even if she was there, she might have been sent home. So, a lot of really interesting data that's come out of this. So there's been a lot of partnerships looking at youth sports too. So this is from the AAP, the American Academy of Pediatrics, NATA, and the American Medical Society of Sports Medicine. They put out this, what they call Play Informed, and kind of gave out some guidelines. And some of this has become a little bit, it has been changed and modified as we've gained more data. So I'm not going to go through all of that there, but it shows you where we've been and partnerships that have risen, and there's been lots of guidelines that have been constantly coming out and updated. This is the American Red Cross put this out, but this is from the CDC, looking at what do we think is highest risk and lowest risk. So obviously individual skills or skill building drills, or if you're at home and you're out, doing soccer drills in your backyard, pretty low risk. Then you move on to sort of a team-based practice, and again, probably outdoors versus indoors, we'll talk about, is going to be a little higher risk. And then within team competition, so scrimmages versus drills, then competition between teams from the same geographic area, and then competition between teams from different geographic areas. So obviously, if you have a tournament where people are traveling from all over, and you're indoors and you're interacting with lots of people, but again, is it the actual sport or is it the community transmission that you're getting? Just makes sense, right? If we're bringing lots of people together from different areas, when maybe it makes sense to go a little bit different direction. And so some of this may or may not be relevant as we wax and wane and have different strains that come through. Right now we're in a fairly low COVID level, but it's creeping back up again. And so some of us have recently had it. There's a lot, I know a lot of people that have recently had it and are still recovering. We've got a lot of athletes that are still getting it. We've had patients that have canceled appointments because they have COVID. So we're still seeing a lot of this. That transmission risk is still there. And so again, this doesn't necessarily change the risk. Here's a nice little graph that I think shows, low risk versus high risk. So again, individual sports that allow 6 to 8 feet between other competitors, tennis, for example, probably lower risk. Sports with frequent close contact, so showing soccer there, you're face to face there. If you're sharing equipment, it's going to be higher risk. If your interactions are longer than 15 minutes, it's going to be higher risk. Indoor spaces clearly are higher risk than outdoor spaces. So when we look at sports that are high risk, so when we kind of come back to, for example, wrestling would be close contact, and longer exposures, interactions one-to-one, indoor spaces, and then maybe you've got a group events where, wrestling tournament, traveling and playing outside your community. Everybody gets on the bus and rides together to the wrestling tournament. Face coverings, if you're wearing face coverings, we do think that reduces the risk of transmission. And then obviously if everybody else is following the rules. And one of the biggest things is not showing up if you're symptomatic. I mean, I think that's sort of a obvious. Obviously, if somebody's asymptomatic, it's harder for us to detect that without screening testing. But it's pretty easy if somebody has symptoms and they show up, that we know that that's going to be a higher risk of transmission. And so it's incumbent on everybody to be honest and to pull themselves out. And unfortunately, that's not where we are. But when we have people who do show up symptomatic, then they place everybody at a much higher risk. So this came out of that AAP and ATA and AMSSM guidelines. The AAP has continued to update their interim guidelines as well. And so this is due to be retired actually at the end of this month. And in one of my roles working with the AAP, we recently were discussing whether or not to retire it or to keep it, because we feel like some of it is sort of fallen out a little bit. But it was recently decided we should probably continue it because this data is relevant to a lot of us. And a lot of this is important for us to know. So the AAP strongly recommends opportunities for children and adolescents to participate in sports. And as long as mitigation strategies are in place and local authorities approve. And so, we're not saying what mitigation strategies you have to have in place, but do your best, be smart. Again, if somebody's symptomatic, don't come. But obviously we know the benefits of sport participation. Everybody that's in this room knows the benefits of sport participation. We all live in this world, and but we're seeing that. So we want them playing. We know that they're at significant risk of injury, and we saw this for sure when athletes were coming back. They're talking about growth plate injuries, muscle strains, stress fractures. After they've had weight gain, maybe that obesity's crept up, they're trying to get back in training, the deconditioning that we talked about, and then maybe they're going outside after they haven't been. So we were confined March and April, and now we're getting back maybe May or June in the heat of the summer, going back out, so heat-related illness. So being aware, just like any other time that somebody's been away from their sport for a while, that ramping them up immediately is probably not a good idea, but there was a lot of excitement. There was a lot of people that wanted to get back. They'd been cooped up at home. The coaches were happy to have their athletes back. And so what did we do? We hit the ground running just like we hadn't been out, and we took advantage of it. We scheduled tournaments and practices as much as we could, and we got very busy here. We got to see a lot of athletes coming in, and it was a little bit of a different injury pattern, I think, than what we normally see with some of the things that we kind of saw more of, and we could say, yeah, unfortunately, we're seeing this. It makes a lot of sense. So as far as preseason sports exams or seeing your pediatrician, the pre-participation physical evaluation, we want pediatricians and PCPs to ask about recent COVID infections or any COVID infection, ask about vaccination and status and booster status since the last evaluation, and document it so we know. We also recommend, the AAP recommends that all people who are eligible should be vaccinated and should receive a booster dose and continue to follow guidelines. So face masks has also evolved a little bit. This one still says it's strongly recommended that everybody wears a mask indoors, even if they're vaccinated, if their county is in the high level as defined by the CDC community level system. So if you have a lot of high COVID transmission in your county at the time, still probably makes sense for everybody to be masked. And then when it's appropriate, you have to think about wearing masks elsewhere. Nobody under 2, and then if there's any risk of heat illness, you be careful with that. What we found is that most athletes can become accustomed to training in their mask. It was not that much of a deal. The first day, it was kind of annoying. The second day, okay, and by the third day, most athletes didn't even notice it. So even at the elite level or collegiate level, again, back in 2020, there were some very big Division I universities that were having all of their athletes train in face masks. And really the feedback from the athletes was it really wasn't that big of a deal. It didn't really impact their conditioning or whatnot. And so if it made sense, then they were able to do that. Sports where obviously there's an increased risk of either obstructing your vision or strangulation, such as you know, if you can't see, cheerleading or gymnastics, you're tumbling and your mask rides up and you can't see. Swimming, unfortunately we have to put out guidelines that says please don't wear a mask when you're underwater and swimming because it's going to be really hard for you to breathe. But that's there too, so don't do that. Anybody with signs of symptoms of infection should not attend practices or competition. Again, I think that pretty much is very self-explanatory, but unfortunately needs to be continue to be repeated because a lot of people don't follow that guideline. But in and of itself, that one guideline can make a big difference in terms of mitigation of transmission risk to others, players and coaches. It's not, again, not necessarily the sport itself, but being around everybody else, just like at school. We don't want you going to school symptomatic. We don't want you coming to sports symptomatic. Consult with your pediatrician and notify people if you have been symptomatic, and notify them if you have symptoms so that we can kind of pay attention to that. So, we're talking about how to reduce the risk of transmission, but what is the risk? So when we start to look at, this is one of the things that kind of prompted the Big Ten and the Pac-12 to cancel football. So came out September of 2020. They looked at, well, it was published in September 2020, but the data was available before that. They looked from June through August at 26 collegiate athletes. This is up from Ohio State. And they found that 12 athletes reported mild symptoms during their infection. The others were asymptomatic. So these were 26 athletes with COVID, age of about 19, 20. Their EKGs were all normal, and echocardiograms normal, okay? So then what they did is they looked at their cardiac MRI, and they found that 4 out of the 26, or 15%, had findings on their MRI consistent with myocarditis. So you can imagine, with as many COVID cases as we have, asymptomatic or symptomatic, if 15% of our athletes have myocarditis, we're worried. We're worried. That's a big number, trying to put people back on the field. And so then 8 additional athletes above and beyond the 4 that had what they call late gadolinium enhancement, which basically is a marker of myocardial injury without full myocarditis, but had some markings. So 45% of these athletes either had true myocarditis on the MRI or some marker of indication of myocardial injury. So again, almost half. So this was one of those studies that came out and everybody said, whoa, let's stop and pay attention because we can't play sports. This virus clearly must be different than the flu and other viruses that have been circulating for a long time that we know can cause myocarditis or inflammation of the heart muscle, which can then lead to arrhythmias, which can lead to death. And so myocarditis and fever are the 2 things that are contraindications to sport participation. If you've got myocarditis, you're not cleared to participate. If you've got a fever, you're not cleared to participate. And so that's a big issue, right? So then the Big Ten and the Pac-12, when they were looking at this data, this was one of the big drivers to them, in addition to the risk of actual COVID transmission that they didn't know at the time because they didn't have the SEC data and these other Olympics and everything to sort of rely back on. They didn't know, but they said, look, our athlete safety, the school administrators and the attorneys, looked at this and said, we can't have football right now. So August 11th, August 12th, they came out and said, we're not having football. And then you had the Big 12 and the SEC kind of wavered. And part of it is we said, well, we're relying a lot of this on this one study. So there was another study that came out. This was looking over the course of that 2020-21 season. So college athletes, and these were athletes who had EKGs at baseline. So they were able to get an EKG at baseline. And then they looked at 370 athletes who had COVID. So they had their pre-COVID EKG. And then after they had COVID, they were able to test them again do an EKG. And they found that 4% had an abnormal EKG with COVID. So again, they're saying, okay, well, 4% is still a pretty high number if 4% of our athletes are having some changes to their EKG, because we know their baseline, just like an impact test, right? We're seeing something here. There's some changes. So that was a little bit of a concern. So then you start to look back. Okay, those were small scale studies early on in the information phase, gathering phase. So now you start to look at some of the data that's been coming out more recently. So this is from May 2022. Okay, this was just published last month. Now they looked at data from September 2020 to November of 2021. So now we've got a lot more athletes. Instead of those 26 that we had originally in Ohio State, we have 3,700 collegiate athletes, 45 universities, 27 different sports. And they had either EKG, they had either what we call the triad, which is EKG, troponin testing, and echocardiogram, or they had cardiac MRI on 97% of those athletes. And so they found these are athletes who had COVID. Now, they found only 0.6%, so only 21 athletes had definite or probable COVID-related myocardial or myopericardial involvement. So 0.6% versus 15% versus 45% versus 4%, that's a huge difference, in terms of the changes in there. So now when we look at a large scale, and then of those athletes who had cardiac involvement, they were restricted and they were all able to successfully return within the average range was about 3 months after their initial infection. So everybody was able to get back safely, even those who had the changes there, but we're only looking at 0.6% that had any changes. So this is looking at those athletes, 3,700 of them, 21 athletes who had definite or probable cardiac involvement, no adverse outcomes. So then we had 3,600 without cardiac involvement. We had 2 adverse outcomes out of, again, 3,700 athletes who had COVID, only 2 outcomes, and one of them they said was not related to SARS, and then one had atrial fibrillation, which may have been related to SARS or COVID, but that's it. So pretty good data just last month coming out saying that maybe there's not nearly as high a risk of myocarditis as we thought. So then we look at symptoms. What about persistent symptoms and exertional symptoms? So persistent symptoms, there were only 40 that had persistent symptoms out of those 3,600 and only 137 who had exertional symptoms. So very small percent. And of those, persistent symptoms are loss of taste and smell in 2/3 of them. So we don't really worry about loss of taste and smell as when we're looking at symptom-free and kind of getting them back to sports. We don't think that has anything to do with cardiac involvement or any long-term concerns. So not a big deal there. Shortness of breath, cough, chest pain, fatigue, and in smaller proportions of them. But exertional symptoms, shortness of breath, 60%, chest pain, 36%, exercise intolerance, palpitations, and presyncope. So I want you to look at those symptoms there. Those are important symptoms to us as we start to go through this. Shortness of breath on exertion, chest pain, exercise intolerance, not just being deconditioned, but not being able to tolerate exercise to the extent that you expect them to, chest palpitations or fainting, syncope or presyncope. So when we look at those who had persistent symptoms, so this was those that came back and what symptoms they had and then what their underlying condition was. So I thought this was interesting because those with chest pain only or multiple symptoms with chest pain, which is about 35% of the group, had pericardial, myopericardial, and pericardial issues. So they had heart-related issues. Again, these are the ones who actually had any issues. And then those who had shortness of breath had pneumonia or pleural effusion, so they had lung-related issues. It kind of makes sense. So again, coming back to when we start to kind of narrow it down, maybe not everybody's at risk, and maybe you can kind of start to listen to what symptoms they're having when they're going back, and that tells you who may be at higher risk for heart involvement. So chest pain, so there's none of these that didn't have chest pain ended up having some sort of myocardial inflammation there. So they found that there's a low prevalence of persistent symptoms greater than 3 weeks out from illness. So 99% of these athletes recovered within 3 weeks, and a low prevalence of exertional symptoms. So 96% of them didn't have any exertional symptoms at all. So that means that 4% did have some exertional symptoms when they got back. They were symptom-free, but when we tried to exert them, had some symptoms. No athlete with isolated persistent symptoms alone was diagnosed with any COVID-related sequelae. But exertional chest pain on return to exercise, probable or definite COVID cardiac involvement was found in 20% of cases. So we looked at 0.6% of the total group, but of those who had chest pain on exertion, 1 in 5 had COVID-related cardiac involvement. So again, we're starting to narrow down what can we look at when we're going back to return to play in terms of concerns. So how does this impact us? Again, exertional cardiopulmonary symptoms on return to exercise, particularly chest pain, warrants further evaluation, and cardiac MRI only considered in athletes with exertional chest pain after an investigation. So our next question. All of the following are recommended for return to play following COVID, except they've completed their isolation period, they don't have any cardiopulmonary symptoms with exertion, they have a normal EKG, or they've been cleared by their PCP. a little bit harder. So these are recommendations. Okay. I don't know if it's not working because I'm not seeing anything pop up. I got 11 people signing in. Let's see here. Has somebody put in an answer? Yes? Okay. It may not be working. Oh, there we go. Good. Okay, so yeah, so a little bit of a different here. So we got, okay, normal EKG is what 60% of people said. Yep. So, okay. So when we look at the actual guidelines, there's lots of different guidelines, but they overlap in some key areas. So we'll kind of just talk about what we really want to do. Essentially, when somebody's had an infection, they isolate according to whatever the protocol and the guidelines are. Typically right now, that's 5 days of isolation. Okay, and then we're going to stratify them based on the severity of the illness and then maybe presence or absence of cardiopulmonary symptoms. So if they have an asymptomatic or mild illness, we're going to treat them differently than somebody who had a moderate illness, or if they had cardiopulmonary symptoms at the initial phase, which is different than somebody who has cardiopulmonary symptoms when they go back to exercise. And again, when I'm talking about cardiopulmonary symptoms, exertional chest pain, shortness of breath, exercise intolerance, palpitations, your heart beating fast, or syncope, passing out, or feeling lightheaded, and then obviously severe illness. And so essentially, the guidelines, whether it's the AMSSM and the National Federation of High School Sports, or the AAP or the ACC, we stratify them based on this. And if they're asymptomatic or mild, and they define mild differently than in different areas, but everybody kind of recommends checking in with your PCP. So again, that's why I said recommend. It's not required, but it's check in. We used to require clearance. But whether that's your, whoever your PCP or pediatrician is, check in with them. Let them at least screen you. Primarily, we're screening for any cardiopulmonary symptoms, any severity of illness, and then rest for a few days, and then gradually get back into things. If they're more significant, then we kind of go a little bit further. So asymptomatic or mild, this is the AAP guidelines. Same thing, asymptomatic or mild, at least a phone or telemedicine check-in. So this can be just a phone call to the PCP's office. Make sure that they've isolated, make sure that they're not exercising early on, and then looking for symptoms. And if they have symptoms, then we bring them in, do a full evaluation, refer to cardiology if there's any concern at all, and if there's not, then clear to return to play. Excuse me. And then again, more moderate symptoms, we're much more likely to kind of do a little bit of an evaluation, bring them in as opposed to just a telephone clearance. But that doesn't necessarily mean that they all need to go see the cardiologist. But again, any positive symptom screen, if they have an abnormal exam, or if you do an EKG and it's abnormal, then you refer them on. However, if they've had severe COVID, they've been in the ICU, they've been intubated, or they have the multi-inflammatory syndrome, then they're going to be restricted from that 3 to 6 months. And again, we think there's probably a much higher likelihood of myocarditis and cardiac involvement in that group. And so that's why they're being held out longer. So when can they go back? When they've completed isolation, they can perform normal daily activities, they don't have any concerning signs or symptoms, and then they can progress back according to their own tolerance. Younger kids, we think, are at lower risk than adolescents. So if they're under 12, they can just basically go back to PE and normal activities if they're doing okay. Now, I might argue that, some of our 10-year-old elite athletes I would treat similarly to some of our 14, 15-year-old elite, adolescent athletes. But in general, if they're adolescent or adult, they should go back gradually, and the length of the period is variable. On the AAP says 7 days, maybe 3 days, maybe 5 days. I think you can individualize it to the athlete in this situation, and if they're asymptomatic, you can progress them fairly quickly. But similar to, again, concussion, when we come back from a concussion, we progress them back gradually. I think similar concept to this. You stratify and you kind of progress them back gradually. And if there's any symptoms upon exertion, then those are high risk. And so this is just clarifying that if they're asymptomatic, they have symptom-free, and then they progress back, within 3 days, if they're symptomatic or mild. And if they're moderate, then maybe it's 5 to 7 days. This is still from the same AAP guidelines, so they've given us 3, 5, and 7 in the same guidelines, depending on kind of how it is. So it just kind of varies based on the patient. They do recommend a face mask for all physical activity, including games or scrimmages, until they're 10 days out from their positive test. So they're still in that They have 5 days of isolation, and then there's still 5 days of masking after that. So even if they're asymptomatic and they are returning to sport, their risk they're still infectious and contagious. So it's not necessarily about their individual risk of paying, but that's what they're suggesting is if they're going to be around teammates and others. So this is an example of that return to play. The UIL still strongly recommends that clearance from a physician or physician-approved delegate. So again, it's not required. Initially, it was required, but then they changed it in January to say strongly recommends, so that's why it's still recommended clearance from your clinician. There are no current they're not currently limiting capacity. So we have full stands. We did previously have some limitations on spectators, but there's no limitations there. Masks are not required. The UIL still wants you to notify of positive or cases. And obviously, again, don't send your child to school or sports if they have COVID-19. So some of the take-home points from the American Cardiology is basically cardiac testing is not required for everybody. The prevalence of myocarditis is much lower than we thought. Routine cardiac MRI is not recommended. Return to play can go back much sooner than we previously thought. Everybody, if they have symptoms, even if they don't have symptoms, should implement a graduated return to play. And those are the highlights of this. I like this one. This was from Dr. John Finoff, who's our U.S. Olympic team physician. And he was kind of just comparing 2020 to 2022, and there's been a lot of changes. Just like with concussion evolution, we're getting them back faster, we're getting them back sooner, we're requiring less testing and less restrictive requirements based on the data that I presented to you today. We have some data to now base these decisions on, whereas we did not 2 years ago. So with that, I think sport participation is safe with appropriate COVID mitigation efforts in place. The risk of myocarditis in athletes following COVID infection is low. Cardiac testing should be guided by illness severity and by symptoms. And the presence of shortness of breath, chest pain, especially chest pain, palpitations, syncope, or exercise intolerance warrant further evaluation. So I thank you for your attention, and I think we have maybe a minute or two for questions. So it's a good question. The UIL suggests following the AAP, the American Academy of Pediatrics, or the American College of Cardiology guidelines. The American College of Cardiology guidelines sometimes are a little bit more adult-focused, and so I think that the American Academy of Pediatrics, or the AAP, it has continued to update their interim guidelines, and we're most recently updated in March, and with any relevant changes, and I think that that's probably still helpful, and again, most pediatrics focused. Thank
Dr.
you for that
Miller,
question.
really appreciate your talk. I thought that was very insightful and certainly a helpful talk for parents and providers and all of us that deal with this on a day-to-day basis from the sports world. So we really appreciate you taking the time to put that together for us, and thank you guys all for attending.
Thank you for your attention.